How does it impact your personal performance as a surgeon, for instance? Like I don't know how. I mean, I know like when I was operating, I liked to be everything done within an hour. I didn't like to spend 3-4 hours in the operating. I was in residency where I'd sit there scrubbed into assisting in some 16-hour hip revision. You just hated being there that long. And because you get hungry, you get tired, you get bored. It's just holding retractors for God knows how long.
Yeah.
How's your performance in the operating room now?
It's I would say I've only been in the operating room since I really was eating ketogenic and carnivore. So I haven't really tried it eating just a standard diet. But I can I just came from a night shift earlier today, and you don't really sleep that well. So what I do is I try to eat as early as possible, and obviously eat a lot of whole foods, a lot of meat, a bit of rice. So my energy levels are like stable and don't go up and down. I don't feel the need for like a break. And as you know, with GI surgeries, we have to stand there for 4, 5, 6 hours sometimes, finding the issue, solving the issue. And it's not an issue. You get thirsty a bit, but I never get tired. I never feel like that I can't do this. I used to do, when I did intermittent fasting, I would actually eat after my shift was done at 3, 4 p.m. So I wouldn't eat from between dinner the day before until 3, 4 p.m. till my shift was done the day afterwards. So it's not an issue at all. I have very stable energy levels.
Yeah, it's kind of interesting because, a lot of people, you see, a lot of us have experienced eating carbohydrates. You'll eat a meal and then you'll get real sleepy afterwards. And you can imagine, you've got a surgeon who maybe he's got a big old belly and he went to lunch and he had a bunch of, whatever. He had some cake for dessert.
Yeah.
And now he's operating on you, and about an hour into the surgery, he's starting to get like, well, I'm a little sleepy in here.
Yeah.
It's not a good situation. You think about that, but I mean, just kind of like, hey, what did you have for lunch, dude? You're going to fall asleep during the surgery on me? So it's it is. I mean, you could probably look at performance metrics on surgeons based on different diets and, outcomes. Cause we all make mistakes, and we all, we're all subject to the same things everybody else are. Do you find that, as far as, I know in the situation in the United States where, we've got the USDA and they're compromised by all the conflicts of interest, is Denmark basically just following the U.S. guideline, lockstep? Are they just pretty much whatever the U.S. does, we're going to do, nutrition and health wise?
Yeah. We are. I would say we're probably a couple of years behind, but we're definitely on the same line. We also have the same food pyramid. We follow the European guidelines, which are created by the same companies that create the US guidelines.
Yeah.
So we're just a couple of years behind.
I noticed how you said the same companies, which is kind of interesting because we're supposed to have these independent, objective organizations, USDA, FDA, whatever. And it's really is. It's these companies that are creating these guidelines and in order to sell their own particular products and stuff like that. What is the traditional diet of the people of Denmark? I mean, if we had to go back, 100 years, some people are more seafood eaters. What does it look like?
A lot of potatoes and some meat, and then some gravy. That's like a very traditional Danish food. So I would say calories would be. They recommend 60 to 70% of caloric intake should be from carbs, and Danish people do eat that. They eat a lot of potatoes. Yeah,
I often wonder, these recommendations, and this is kind of similar. U.S. guidelines are somewhere in that 60% range from carbohydrates, and it's just because they're cheap to produce. It's putting less stress on the food system. And they're like, well, we're going to just give you kind of like, it's kind of the overall population. We can't afford everybody to eat well. Let's just give them the basics so they don't starve. And that's kind of I think that's what we're operating on. How is obesity there relative? Like in the United States, our current obesity rates are something at 42% before COVID pandemic. It's probably closer to, I'm guessing probably 45% right now, and soon will be 50%. Probably by 2030, we'll be at 50% obesity rate. What are we looking at in Denmark?
So I don't have the exact numbers, but I think we were around 15 to 20%.
Yeah, so about half.
Maybe 25%.
About half what we are, which is because I was in the UK a couple months ago, or August, and I was just kind of like, well, there's not as many obese people here, as compared to when I go home, which is it's good, but I mean, they're catching up. That's the problem. They're starting to catch up.
Definitely. I mean, if you look at Eastern Europe, for example, there's way, way less obese people. I was in Poland a couple of months ago, and you never see obese young people. Like, it's almost impossible to see obese young people in Eastern Europe. It's just not socially acceptable to be obese when you're 25 or 35. So,
yeah, it shouldn't be at any age, to be honest. But I mean, it is kind of a shame when I go out and I see, young men in their 20s and they're already obese. They already look like they've got metabolic disease, and it's they're not setting themselves up for a long, happy life, for sure. What is as far as your sort of surgical practice? Are you seeing are you seeing younger and younger patients with problems, or what's it? I mean, obviously you haven't been in long enough to say what it was like 20 years ago, but I mean, what does a typical night of call look like for you? What do you see? Are you seeing trauma? Are you seeing bowel perforations and bowel obstructions? What's going on there?
We see a lot of gallbladders, cholecystitis, a lot of that. Yeah. And I would say that's what we mainly see.
Why do you think that is? I mean, when I went to medical school, I remember it was a 4F. It was fat, female, fertile, and 40 was the mnemonic we used to use to learn about cholelithiasis. And we see that, I mean, and what's causing, what do you think is causing all this gallbladder issues? I mean, it's an organ we have. I mean, it's there for a reason, right?
Mm-hmm. Yeah, I think it's definitely some sort of insulin resistance that's causing the issue. I think that is the main driver of cholecystitis.
So I mean, who is like your typical patient that you see roll into the OR that has a hot gallbladder, needs to come out? What do they look like? What's going on? Are they typically metabolic syndrome?
Yeah, they are. Like they definitely have hypertension. They usually have diabetes, and they're usually, I would say, between 40 and 50 years old when they have the issue for the first time. We're getting some younger patients, actually, like mid-20s with stones in the gallbladder that's giving them issues. So we're definitely getting younger patients. But I would say the main patients are between 35 to 50. And those are the ones that we remove.
And what percentage of those patients are on a carnivore diet?
Definitely 0%.
Yeah, interesting. It's kind of, it'd be interesting to see. I mean, I suspect, like some people will posit that because we're on these low-fat diets, and the gallbladder's job is to contract and squirt bile into the duodenum, and we're not stimulating with these low-fat diets, and so the bile just sits there and forms a sludge, and eventually we get the crystallization and the stones forming. And so that's an interesting thought. That if you look at what is the function of the gallbladder, it's literally to squeeze bile in so we can break down fat, emulsify fat. So interesting.
Yeah, that's interesting, actually.
Now, as far as you said you've got these entrepreneurs and businessmen, you mentioned, as far as diet, obviously you said you started them on a carnivore diet. What other type of things are you working on with them? Strength training, or what's going on there?
So it's, I usually have a couple of pillars where food is one of them. Training is a second one. Then we have sleep, which is also very, very important, stress management, and then water intake. So that's usually how I categorize the different stuff that I work with them on. And food is one of the biggest ones, training as well, and then sleep. Because stress management can be different stuff. People like to be, some people are religious, and that's how they manage their stress. I advocate both I would say a relaxed stress management way and a physical way of stress management with training, physical training, like going out and like literally doing boxing on a bag. That's a very good way of managing stress. Meditation is another good way of managing stress as well. It's just two different, it's polar opposites, but they do the same things. And sometimes you need one, and sometimes you need the other one. That's basically what I work with. And I focus a lot on sleep as well, because people are just sleep deprived mostly.
Yeah, I was just remembering the name of the person that was in Copenhagen, Don Layton. she's an ER physician over there, and she's on carnivore. So you have another carnivore MD in that area. So that if you if you're looking for some sort of somebody that supports you in the same way. Have you been able to, like you said, all the people that sort of watch you and ask you questions, have any of them converted over or like started trying that, in the hospital?
For my patients in the hospital, I don't think any have really. I had a discussion with one of my older colleagues the other day, actually, because he has a cardiovascular disease, and he's going to this rehabilitation center where they're teaching them what to eat and how to train and all this stuff. And I gently, started talking to him about it, about how he should maybe not follow those guidelines, but maybe actually eat more saturated fats and eat more meat. And he was very interested. So I sent him over a couple of articles 2 days ago, and we'll see what happens from there. But he was very open to it. And but in terms of patients, I haven't really worked on converting people like that, because it's not really I have to be honest and say it's not really a risk that I want to take going against the guidelines when I work at the hospital. And